welcome our first speaker for this session. He's Prof. Jorge Hidalgo, and he is a professor of critical care and the head of the Division of Critical Care at the Carl Hoster Memorial Hospital in Belize City, Belize. He is a graduate of, with a degree of medicine from the Center of University of Occidental Guatemala before completing his residency in internal medicine at the Roosevelt University. He is a well-known and respected speaker locally and internationally, and regularly contributor to chapter and books of critical care medicine. He is the founder and associate editor of the Belize Journal of Medicine, and currently the president of the World Federation of Intensive and Critical Care. So please welcome with me, Prof. Jorge Hidalgo, and the mic is yours, Prof.
Thank you. And first of all, thank you to the organizer, to the invitation to be in this fantastic conference, and of course, beautiful country. I'm really enjoying my time in Kuwait, and thank you. And of course, it's very difficult to cover an important topic of critical care during pregnancy in 20 minutes. I mean that I will just give you a glimpse of what should be the importance and what we need to take in consideration when we are dealing with critical ill pregnant women. My conflict of interest, we are writing several books regarding critical care in pregnancy, and we are now preparing this collection of 7 books. We already have 3 of them, 4 are to come, and are just dedicated to critical care. This is my ICU. I used to ready to enter the ICU and start the day. And of course, what the objectives of this talk should be basically is to explore the unique challenges that we face when we are dealing with a critical ill pregnant patient. And we will do some insights and of how we approach this type of patients. And of course, it's a very important topic since, of course, is maternal critical illness still one of the main cause of reasons for mortality, especially in the low resort settings. And we most of the time are going to face very complex scenarios with this type of patients. And it's really a topic of importance when a maternal patient die in one of our ICU is a country a case, meaning that everybody is called, the Ministry of Health call everyone and trying to understand and to see what happened with the patient, because it's the way they are measured. I mean that mortality in the maternal area is a country concern. I mean, more or less an average based on this WHO sheet say that 295,000 maternal deaths occur annually, with a 94% in the low resort setting. Of course, it's very difficult to ensure those numbers since, of course, it's very difficult to run clinical trials in this group of patients, but more or less this is an idea about what happened in the low resource countries. Of course, in countries with most resources, the mortality is not that bad, but still something that we need to have in consideration. One of the main reasons we, of course, see as cause of seeing these patients is we see obstetric hemorrhage, hypertensive disorders, and sepsis as one of the 3 most important ones, and there are others, no? And of course, there are some geographic disparities that we need to have in mind, and especially in regions like Africa, especially in South Asia, that they probably has the highest burden of mortality in this group of patients. I mean that when we are admitting a critical ill patient in our ICUs is a very area of concern, because of course we are facing with an uncommon group of patients that we normally deal, especially we are in a general ICU, And the success of manage these patients is going to basically base on how we are going to do our assessment to this group of patients, our understanding about the physiological changes that are associated with pregnancy, the pregnancy-specific conditions that we are going to review in the following slides, and the presence of the fetus, our familiarity with this type of condition as a clinicians. Mean that it represents definitely a very unique clinical challenging for us dealing with this type of patients. And we know already that the presence of the fetus itself, the well-being of the fetus, it will depend on how we are going to deal and to manage the patient primarily. And in the case of the obstetric patients, we understand and we know that the uterine displacement should be considered as one of the initial priorities when we are going to see these patients and part of the ABC evaluation in the hemodynamically stable obstetric patient. And this is just a picture for us to see what should be the appropriate immobilization of the pregnant patient, especially the trauma patient in the emergency room, ensuring this displacement on the uterus to secure the perfusion of the vena cava. Other important thing is if we are seeing patients in childbearing age, we need to ensure that we run a pregnancy test because, of course, especially in the emergency room and in the trauma room, many of the things we are going to do probably are going to be affected based on if the patient is or not pregnant. And as we normally do in ICU, the most important thing in management of a critical ill patient is our team approach. We need to ensure that we are going to treat the greatest threat of the life first. We need to ensure that of course, we are not going to focus on make a diagnosis, but we need to ensure that what is happening with the patient with a physiological approach. The time is critical. And we know that in any patient, but of course in this particular patients, the time is on the essence. And we need to ensure that we are not going to do more further harm to these patients. The teamwork is required to have a very successful management of these patients. And this is just an idea of how we supposed to be created, the team, always someone leading to avoid confusion and to avoid chaos in emergency room or in the obstetric area. Team is on the essence, means that we need to know that we need to do our rapid primary survey and all the different adjuncts that goes with that. We need to do always a secondary and tertiary secondary survey and reevaluation to head to toe to ensure that we are not missing something with this patient. And one of the most important things, we need to recognize what are our capabilities in our hospital if we are or not prepared to deal with this type of patients. If we are not prepared to deal with this type of patients, we need to ensure that we are going to do a proper and safe transfer to a facility that have more resources to deal with these patients. We need to ensure that we are going to send these patients to an area where she can receive a definitive and appropriate care. And for that, we need to create pathways. We need to ensure that we have protocols. Every institution and every country have their own way and their own protocols. However, this is just an idea of a pathway that we need to know if we are going to detect that the patient is deteriorating and that we are going to do an early assessment and response and proper clinical evaluation. Since we are going to do this response, we need to do it on an appropriate and a multidisciplinary approach. We need to know what is the level of care and our capacity, as we already mentioned before. If we are able to solve the problem in our facility, we have all the resources needed to deal with this case, or is something that definitely needs to be referred to a different level of care where more resources are available. And we need to remember all those things that we know already, but it's important for us to always recap and see We know what are the differences in the anatomy, and of course the vulnerabilities of the patient, especially if the patient have a trauma, and depends on what age of pregnancy the patient are, what organs are going to be more prone to damage. Especially when we are already in the second and third trimester, we know that probably the intestines are more protected, but the uterus and the baby are more exposed when we have trauma. I mean, we need to remember that and to have that in consideration when we are dealing with the patients. I mean, the most important thing, as we mentioned already, the best initial treatment for the fetus is to provide optimal resuscitation to the mother. I mean, and now in the following slides, I just want to mention very quickly some of the aspects that we need to remember in terms of what are the different physiological changes that happen during pregnancy. You know, we know that we will experience hemodynamic changes during pregnancy. We need to remember as well that we are going to see certain pathologies in the first trimester. We are going to be facing certain pathologies in the second, and we are going to be a different patient in the third trimester. I mean, it's a continuous, and just we need to be familiar with what is happening with this patient. When we know already, and in the picture, what is happening with the heart rate that is going to be elevated between 10 to 15, the blood volume and the cardiac output, and some changes in the blood pressure that at some point it will affect the way we are going to deal with shock in these patients. We need to know what are the pulmonary changes in pregnancy as well, especially if we are going to planning to ventilate the patient in the third trimester, and some of the adaptations. We're going to see more specific points in the following slide, but just for you to see as summarized, we need to see also what are the neurological changes in pregnancy that we need to take in consideration, and also during gastrointestinal changes that it will probably affecting if we are going to intubate the patient. Remember that the gastric motility is going to be reduced, and then always is going to be more possibilities for these patients to aspirate. Also, we are going to review some, have in consideration some of the urological changes during pregnancy that it can affect, and it can also have these patients prone to urinary tract infections. This is a good summary of the physiological changes during pregnancy in terms of plasma adaptation, the heart rate, the cardiac output. I'm not going to go into the detail, but the slide itself is summarized if you want to take a picture, but it's also the presentation is available if you want to copy, is available for you guys to have it. Also, some of the parameters, and as well to remember what are the different changes. If we are going to intubate a patient, we need to remember what are the different changes that we will have. The airway is going to be more difficult to approach. It's always, by definition, a difficult airway, and we need to be prepared. We need to assess. We need to know what is the diaphragm, the stomach, and the physiological changes in minute mechanical ventilation, oxygen consumption, and some of the functional residual capacities. We need to know and do a proper assessment of the difficulties that we can face, the neck, the face, the mouth, and of course, depends on the time of the pregnancy, what are the problems that we can potentially face, and we need to alert our airway management team because it's going to be a difficult intubation. We need to predict also, we have, as well as we do prediction, and we have all the scores for a regular patient. Some of them can be also adapted, and we can use in patients during pregnancy. Some other classifications that we can use to estimate what are the different levels of difficulty that we can face on a regular, but also during pregnancy. Additional challenges that also it will affect, especially if the preeclampsia is associated, is going to be an additional edema, especially in the tongue, that we can also anticipate the morbid obesity patient plus pregnancy will also add some more difficulties when we are going to approach this airway, and we need to have that in consideration. To intubation, we know that is a risk of fail intubation between 8 to 10 times higher, and also is going to be more or less a risk of death when we fail intubation 13 times greater than in non-pregnant patients, meaning that it's just to address and to emphasize that a pregnant patient is a difficult airway by definition. It's also going to be a more risk and increased risk for aspiration. The probability of a fatal aspiration is 7 times greater in obstetric patients than in those that are not pregnant. And also it's important that we act on time and to take all the different measures to prevent all those things. We need to avoid accidents by non-manipulating the airway too much, especially if we are not really skilled on that. And we need to ensure that we call, and the main
3
goal,
minutes.
thank you, we are almost finished, is to maintain maternal oxygenation, protect the airway, we need to prepare and proceed. Most important than anything, we need to ensure that we have the equipment, that we already call our difficult airway team, the more skilled, and we will try to manipulate the airway the less is possible. We need to remember also that we have the size of the tubes, 6.5, not the 7 that we normally do, because all those different changes. We have also, in other consideration, different causes of acute kidney injury, and we can classify. This one depends on the time of pregnancy. We need to have also all these different renal causes and unrelated conditions that can lead to a kidney injury. And to remember that also the considerations of the creatinine, it will change. We normally see it depends on the way and the nomenclature that you use is 0.5 to 1.4 in a regular patient, but in patients with pregnancy, we consider 0.5 to 0.9 as normal, meaning we have a creatinine on 1, we're already behind. This patient is already in trouble. And some of the effects, one more time, the levels of the creatinine that we are going to consider in these patients are important to remember. This is some other causes of critical illness that are non-obstetric and obstetric causes that it will take these patients to the ICU. Different causes of hypovolemic shock, septic shock, and cardiogenic shock depends on the age of the pregnancy. Causes of ERDS. Remember, this is in case the patients are driving, just to remember what is the right way to put the seatbelt. And
1
that's
minute.
my key points. I'm on time. Then remember that we need to be familiarized with the physiological changes of the patient. That is going to help us as the way how we are going to manage pregnant patient is a difficult airway by definition. With that, I just want to invite you to say the date and hopefully to see you in Vancouver for our World Congress. And then we will take questions at the end.
Thank you, Prof. Thank you very much for the nice talk. We'll keep the questions for after the session. And I'd like my colleague, my co-moderator, Dr. Saeed Yaqub, to present the next speaker.
Thank you very much. Good afternoon, all. It is my pleasure and honor to introduce Professor John Devlin from the USA. He will be speaking to us on post-operative delirium, latest approaches and evidence-based strategies. Okay. Professor Devlin is a professor of pharmacy at Northeastern University, a critical pharmacist and research scientist in the Division of Pulmonary and Critical Care Medicine at the Brigham and Women's Hospital, and an instructor of medicine at Harvard Medical School, Boston, Massachusetts, USA. Dr. Devlin's research program, funded by the NIH Foundation and industry, is focused on the detection, prevention, and treatment of delirium and disrupted sleep in both ICU and post-ICU setting. You are welcome, sir. You have 20 minutes. Thank you very much.
Thank you very, very much for the invitation to speak today to this great audience and to the nice introduction. Thank you very much. I'm going to be talking about postoperative delirium. As we know, many of our patients we care for in the ICU are, have undergone surgery or are about to undergo surgery. And so that's what we'll focus on today. These are my disclosures. I think it's important, to differentiate, though, the surgical patients we care for in the ICU, because we see many patients with elective surgery. Say cardiac surgery is a great example that transitioned through the ICU fairly quickly. And most of these patients are what most of us would not consider to be critically ill. And then, of course, there's the other large population of patients that are have emergent surgery, are critically ill, and spend a lot more time in the intensive care unit. And I think it's important when we look at the literature, these are two brand new guidelines. One's European and one's from the American Society of Anesthesiologists. Most of these guidelines predominantly have enrolled patients with elective major surgery, okay? And so these are different than the patients getting emergent surgery. And so you could certainly extrapolate a lot from these elective surgery patients, but as you'll see in my presentation, a lot of it comes down to when someone has emergent surgery and they present and spend a longer time in the ICU, outside of that perioperative period where they're actually getting they're in the OR, most of it comes down to PET-IS, A to F bundle type recommendations to reduce delirium. So I'll go through these two guidelines, the pertinent things. The recommendations from these guidelines are very similar, so I'm actually going to focus a little bit more on the ASA guidelines. And I think the other thing is most of these guidelines have a real focus on older adults, right? Because we know older adults are our largest surgical population, particularly for elective major surgery. These are patients that often have comorbidities. They're obviously older. They often have higher ASA scores. They have greater frailty, and certainly many have some cognitive decline before they come in for surgery. So these are all some of the top predisposing risk factors for delirium that we see, but they're hard to control for, obviously. You can't make someone less frail or have less comorbidity before they come in for the surgery. I think the other thing that's important in the perioperative delirium world is there's been a focused effort to normalize and sort of standardize the terminology. This has been sort of a worldwide effort. So, the preoperative period is sort of before and during the postoperative period. So this is, looking at, mild or major cognitive decline before the surgery. And then the surgery to hospital discharge is considered is postoperative delirium period. And then discharge to 30 days is delayed neurocognitive recovery. And then 30 days to 1 year is mild or major neurocognitive dysfunction. So it's a little bit different. We've over the last 20 years, the terminology has been quite different. Obviously, it's important to think about risk factors. There's a long list of factors. I talked about many of the patient underlying predisposing factors. There's certainly things about critical illness, organ dysfunction, severity of illness is a big risk factor. Some of these we can control and some of these we can't. But really the factors that we can control are primarily during the actual in the operating room and then in the ICU afterwards. And a lot of these are environmental risk factors in terms of level of sedation, choice of sedation, removing deliriogenic medications, trying to modulate and improve sleep, and early mobilization. So these are probably the biggest risk factors that we want to focus on. So in the 2025 ASA guidelines, one question is, among older adults undergoing major surgery, does neuroaxial anesthesia as the primary anesthetic technique improve postoperative outcomes compared with general anesthesia? 10 randomized control studies have looked at this outcome, and virtually no difference in terms of delirium. And then fewer studies have looked at short and long-term neurocognitive disorder, and virtually no difference. So this is kind of, fairly well established, but the guidelines recommend choosing either neuroaxial or general anesthesia for older adults when either is clinically appropriate. So it's really leaving it up to the anesthesiologist to make these decisions. There's not one strong recommendation. Okay, another question the guidelines pose is among older adults undergoing surgery with general anesthesia, does intravenous anesthesia, so TIVA, for maintenance improve postoperative outcomes compared with inhaled volatile anesthetics? And again, 8 randomized control studies have looked at delirium. No difference in delirium outcomes between these two anesthetic approaches, and no difference in neurocognitive outcomes either. So the ASA in these new guidelines make a recommendation to either use TIVA or inhaled anesthesia. It's acceptable, and it, again, comes down to anesthesiology preferences. There's obviously nuances here, which I'm not going to go into today. What about dexmedetomidine? So among older patients undergoing surgery and anesthesia, does dexmedetomidine administered during the perioperative period, so this includes, just before, during, and immediately after the operation, decrease the risk of postoperative delirium or other adverse cognitive outcomes? So a lot of studies have looked at this, 21 randomized control studies, and they have found a substantial reduction in postoperative delirium with the use of dexmedetomidine in the perioperative period, as well as a significant reduction in neurocognitive outcomes. It's important, though, with dexmedetomidine, depending on the patient, to balance because they found, a significant increase in bradycardia and hypotension. So there's some individualization here. It's a potential benefit, but in some patients who might be hemodynamically unstable, these might be patients where there could be limitations with the use of dexmedetomidine. Sounds like a jet's taking off, but it's interesting when they looked at the sensitivity analysis sort of among these studies, there's substantial differences in when the dexmedetomidine was administered and studied, suggesting that probably it's the perioperative OR period where we're going to get the biggest bang for the buck with dexmedetomidine, using it rather than other in terms of part of the anesthetic regimen. We'll talk a little bit more about DEX versus other options in patients requiring sedation post-surgical when they're in the ICU during mechanical ventilation. It also depends on the surgical site. So, for example, for cardiac surgery patients, the benefit's not really there. There's a lot of heterogeneity between studies, whereas with thoracic surgery and orthopedic surgery, the benefit's greater. And also with abdominal surgery, there's not really the benefit seen in the 4 studies looking at that. And then and so it's important there's some heterogeneity here, but they do make the recommendation among older adults scheduled for inpatient procedures, it is reasonable to consider dexmedetomidine. I'll just keep going, it's okay. Consider dexmedetomidine to lower risk of postoperative delirium while also considering its effects on bradycardia and hypotension. So when we're in the ICU, though, what about using dexmedetomidine to prevent delirium? I led a large study that was published in the Blue Journal a few years ago where we took patients that were receiving invasive mechanical ventilation with either benzodiazepines or propofol, and we added, in a placebo randomized control study, we added low-dose nocturnal dexmedetomidine with the hypothesis this might improve sleep, reduce GABAergic sedatives, and reduce delirium. And we actually found there was a 44% reduction in incident delirium in the dexmedetomidine treated group. So about half the patients were post-surgical patients. Again, we weren't using dexmedetomidine in the immediate perioperative period. This is later in the ICU. We didn't find any differences in sleep, but we were using just patient self-reported sleep, so not a great measure of sleep. So it suggests that there may be some benefits of giving dexmedetomidine at night to reduce sleep. And there's been a couple of cardiac surgery studies where they're using dexmedetomidine post-surgical at very low doses at night that have also been shown to reduce delirium. We certainly know benzodiazepines are very deliriogenic. The more benzos you give to patients in the ICU, the greater the patient has risk of the patient transitioning from no delirium to delirium the next day. But it's interesting, this paper just came out, I just happened to see it, it came out 3 days ago in JAMA, and it's looking at using benzodiazepine-free cardiac anesthesia for reducing postoperative delirium. And they found there was a trend. Basically what they compared is a very restrictive benzodiazepine policy, so during induction and throughout the OR, no benzodiazepines. And then the liberal benzodiazepine policy was, either with induction and throughout surgery. And they found when they looked at postoperative delirium in the first 3 days, they found there was a reduction, but it was not statistically significant. So it suggests that this might be beneficial, but depends on, how important that p-value is to clinicians. They didn't find any safety-related issues in this large cluster randomized controlled study, but it wasn't quite as definitive because I was expecting that they might show much less delirium in these patients. So what about patients that are, in the ICU and require continuous sedation? Just like Yahya Shahabi's SPICE-3 study, the MENS-2 study that I was involved, compared dexmedetomidine to propofol for sedation mechanically ventilated patients with sepsis. These were sick patients. About 30% of them were post-surgical. We started the dexmedetomidine. We randomized patients on average about 2 days after mechanical ventilation and starting sedation. Found no difference in days spent without delirium or coma. Patients were reasonably awake and very adherent to the 8F bundle. Looking at long-term effects like cognition, no difference between the dexmedetomidine and propofol groups. So the role of dexmedetomidine, looks like it has some advantages in the perioperative period. But again, a lot of that data is in elective surgery patients and potentially has a role at night for nocturnal sedation. But comparing to propofol, whether it's cardiac surgery or major sepsis or ARDS, its role as a huge benefit over, say, propofol, it hasn't been as well elucidated in sort of the much sicker critically ill adults. So I think the recommendation that we made in the PAD-IS guidelines suggesting either propofol or dexmedetomidine for, sedation in mechanically ventilated adults still stands. One of the other, as a pharmacist, one of the other important guideline recommendations in the 2025 ASA guidelines was the question among older adults undergoing surgery and anesthesia, do medications with potential central nervous system effects, so neuroactive medications like benzos, antipsychotics, anticholinergics, ketamine, corticosteroids, gabapentin, or NSAIDs, administered during the perioperative period, increase the risk of postoperative delirium or other adverse outcomes? So this is a little bit of a loaded question, and it kind of depends on the agent you're talking about. I think it's important. There's certainly been some large trials. For example, ketamine, Michael Avedon led a huge trial looking at ketamine in the perioperative period and found no difference in delirium reduction. That was the primary outcome. But certainly ketamine and many of these agents are foundational components of a multimodal analgesia approach to try to reduce opioids. We know opioids are, as I think the next speaker will talk about, are highly associated in a dose-related fashion with greater delirium. And so it's a little bit of a complex milieu right now. Certainly a very recent systematic review meta-analysis showed that we need to treat pain. Pain particularly in the geriatric community, is associated, untreated pain is associated with increased delirium, so that's important, and we certainly, most of us have well-established multimodal analgesia protocols in our both elective and emergent surgical patients.
Thank you, sir. 5 minutes more? Yeah.
5 minutes?
Yes,
Okay.
5 minutes. Thank you.
Okay, thank you. And we certainly know, as I mentioned, that there's a strong dose-related effect with opioids and delirium occurrence in the ICU. Looking at ketamine, it kind of depends on the dose. And if you're using ketamine at low doses purely for its analgesic effect, the delirium risk is low. But if you're starting to crank up the dose of delirium, you're seeing a lot of more emergence reactions, you're going to see a lot more delirium. And so it's really, at least at our institution, we really focus on, in our protocols with ketamine, using it at low doses. How about using antipsychotics? There's many small studies looking at various preoperative populations, most of which would never have been in the ICU. Mark van Borgaren in a Dutch group compared haloperidol 1 milligram Q6 or 2 milligrams Q6 versus placebo in patients without delirium, some of which were elective surgery, but all these patients were critically ill, and found virtually no difference in incident delirium or shorter long-term mortality. So certainly in our PAD guide, in the European guidelines, they don't recommend the use of any drugs as a prophylactic measure to reduce the incidence of postoperative delirium. And certainly in our PAD-IS guidelines, we do not suggest using Haldol, antipsychotics. Dexmedetomidine, I think there's a stronger case potentially to a statin or ketamine to prevent delirium. I think sleep's very important. We do make a PAD-IS recommendation to use a non-pharmacologic sleep-promoting protocol, reducing noise and light. Obviously, though, we know it's a much broader and more important topic, including circadian entrainment, and we have a tough time monitoring sleep, right? Patient self-reports aren't particularly sensitive. And so there's a lot of research looking at, addressing some of the Zeitgebers that we know lead to circadian dysrhythmia and try to correct that to try to improve sleep and reduce delirium. Early exercise and mobility, the Schweikart study showed a strong signal that delirium would be reduced when we give mobility early and quickly. And there's an important study from University of Chicago, published in Lancet a couple years ago, looking at the effect of early mobilization. And again, this is early and aggressive compared to not doing anything. And they found a significant reduction in delirium, but also in 50% reduction in cognitive impairment at 1 year. So really seeing, and they had a lot of surgical patients in this study. So obviously, many of you know about the ADAF bundle. It's the best way to put all these recommendations together in our critically ill post-surgical population. Delirium's reduced by 40%, lots of other important patient-related, symptom-related, and system-related outcomes. Even just doing some of the bundle when you're initiating it in your ICU. When your ICU, it has a dose effect on reducing delirium. The interprofessional team is so important. Everybody working together to do their role in managing and implementing the ADEF bundle on a 24/7 basis. Really important to build this in the team round, put it in your electronic health record. And what we'll see with patients that come in, particularly if they're older adults that are critically ill post-surgical, is that by doing all these perioperative and ICU efforts, that the patient will hopefully survive their ICU illness and get back to doing the things they like to do, like golfing or bridge or whatever they like to do to recovery. That's the most important thing to patients and their families. Thank you very much.
Thank you very much, Professor Devlin, for the great talk on postoperative delirium. Thank you. Okay, my co-moderator will introduce the next speaker. Thank you.
Thank you. We're keeping with the pharmacy and critical care. So our next speaker is Dr. Ahoud Al-Juhani from Saudi Arabia. She's the founder of the Saudi Critical Care Pharmacy Research from King Abdulaziz University Hospital. Her areas of research interest include critical care research related to trauma and life support, acute pain, sedation, ICU delirium, analgesia, fluid management, patient-related health outcomes, COVID-19 management in critical care setting, and post-ICU survivals, quality of life. She will be speaking about safety of opioid use in critical care versus patient needs for analgesia versus safety of opioid in critical care. Please, Dr. Ahoud, mic is yours.
Assalamu alaikum wa rahmatullah. Good evening, everyone. Thanks for keeping up with us in this late timing and to wrap up the presentations for today. It's of my pleasure to talk about opioid use in critical care, balancing pain relief and patient safety. It's a very wide topic and very hard, honestly, to put in together in just 20 minutes. But I will go over a key aspect of why we are wondering about the safety of our patient when we are dealing with opioid, which is one of the cornerstone and the mainstay agent that we are dealing with it in a day-to-day practice. I have no conflict of interest in relation to the content of this presentation. By the end of this presentation, you will be able to understand the role of opioid in managing pain in critical care settings. I will just refresh your information about their role in managing pain. Then I will identify some short-term as well as long-term risk, why we are really worried about opioid in our ICU patient. I will shed lights also in some aspect that I think beside the short and long-term risk can aggravate some of the poor outcome when we are dealing with opioid in our patient. By the end of the presentation, I will recap by providing you with some patient-centric approaches and strategy to try to balance the efficacy and safety in a critical care when we are dealing with opioid. Just a quick update on the mechanism of action. We all know that opioid are working through mu, kappa, and delta receptor in the central nervous system, trying to modulating pain perception as well as emotional response. Well, what's unique about it in critically ill patient, their pharmacokinetic will alter, either drug metabolism or clearance, and this might affecting drug accumulation and ultimately will affect drug dosing, opioid dosing, as well as the duration of action. Where we need opioid in critical care, yes, definitely. It's one of the mainstay of agent that we utilize on a day-to-day practice. We need it for managing trauma, post-operative pain, any disease requiring some procedure, such as in septic patient or ARDS. Also, it's help in comforting our patient through invasive procedure. For mechanically ventilated patient to reduce discomfort, the guidelines are emphasized on analgesia-based sedation or analgesia-first sedation. And when we look to the guideline, yes, we have non-opioid alternatives or multimodal analgesia, but still opioid remain the mainstay of this regimen, specifically when talking about intubated mechanically ventilated patient. Over 80% of our patients on mechanical ventilation, they're going to receive opioid medication throughout their stays. Critical care guideline is still recommending high-potency IV opioid as first-line sedative for discomfort during mechanical ventilation. As I mentioned, when we are doing analgesia first or analgesia-based sedation, we tend to utilize high-potency. Here I'm referring most commonly used is fentanyl in most of the setting. So proper opioid management is linked with shorter ICU stay and improved patient outcomes, mainly the recovery after ICU discharge, which is a key aspect when we are thinking in developing our ICU protocol or incorporating opioid in our pain management. So in relation to the opioid, there is some aspect that we have to keep on our mind. Also in relation to our patient, there are certain factors that can influence opioid use. First of all, is pain sensitivity. Our patients are not the same in terms of their pain threshold or sensitivity. It could be linked to genetic factor, psychological perception or psychological condition, prior exposure to pain, prior exposure to opioid, certain comorbidities such as substance use disorder, depression, people with the chronic pain syndrome. Also, age and physiological changes, such as I mentioned, older adult or people with altered pharmacokinetic and pharmacodynamic certainly can influence on opioid use. So what are the concerns in terms of the short term as well as long term? Well, the very common concern that we have from opioid use is the suppression of respiratory drive, and it could increase the risk of hypoxemia, hypercapnia, and may delay extubation. Even if you're patient in mechanical ventilation and maybe the depression or respiratory depression is not of that concern, but it might delay the extubation or make a difficult weaning from ventilator. Gastrointestinal dysfunction, delay gastric emptying rate may increase the risk in your ICU patient and increase the risk of aspiration. Chronic opioid use have been linked with immunosuppression. It could delay healing, specifically in patient with infection or patient with post-surgical that require wound healing. In terms of long-term complication and prolonged use of opioid during ICU stay or large doses of opioid have been linked with physical dependence, which complicate post-discharge pain management. A lot of ICU survivors, they recall pain as more terrific and horrible experience. And not only that, they might switch to a chronic pain if we have inadequate or overutilization of opioid, and that's been linked with the use of opioid during their critical care stay. Increased mortality. Interestingly, persistent opioid use after ICU discharge has been linked with increased mortality in one subset of patients who have substance abuse history. Another issue that if we can prevent it, that would be great. And I think us in a multidisciplinary, specifically us as a clinical pharmacist, have a huge impact in preventing iatrogenic opioid withdrawal syndrome. It has a high prevalence rate, up to 32%. It can happen in ICU patient receiving opioid infusion. Rapid tapering or standardized tapering approach that we adopt in ICU sometimes are aggravating iatrogenic opioid withdrawal syndrome. Patient will tend to have more than 5 symptoms of iatrogenic opioid withdrawal, such as anxiety, agitation, tachycardia, and gastrointestinal distress. What's the impact that we have, or what is the negative impact of opioid withdrawal syndrome or iatrogenic opioid withdrawal syndrome? It can certainly prolong the patient ICU stay, which ultimately will delay the recovery and increase the healthcare associated cost. Another issue with opioid is opioid-induced delirium. Dr. John was talking about delirium after OR, and now we have another aggravating factor for such delirium, whether in OR, after OR or in ICU setting. It's the opioid. Opioid is commonly linked with delirium, specifically if we have using high opioid doses in mechanically ventilated patient. Prolonged high doses and prolonged sedation and comorbidity like previous cognitive impairment can aggravate the opioid-linked delirium. It certainly, as I mentioned, will increase all negative outcome, prolong ICU stay, increase mortality, and also have long-term cognitive dysfunction even after ICU discharge, which may impact patient functional capacity and returning to their baseline condition after ICU discharge. Another aspect I would like to talk about, which is not directly related to opioid. We know that we have a very validated tool for pain assessment in patient in ICU, but I want to bring to your attention that is still behaviors that we're going to assess on an intermittent timing. Even if we do it every 1 hour, it still is an intermittent. The reliance purely on behavioral pain assessment tool can lead to inaccuracy in the assessment. And this can link to either overutilization of opioid or underutilization of opioid, leading to inadequate pain relief. So I think our nurses and our doctors have to pay a lot of attention in the accuracy of pain assessment and not depend solely on the behavioral pain assessment. We know that also some physiological indicator might confound the pain assessment. The guideline does not suggest to use them solely. However, integrating different pain assessment tools can help in removing this inconsistent assessment. The reason for inaccuracy, variability in individual response. Well, not all patients respond to pain similarly. And this could lead to, due to cultural influence. Us, for example, in Islam, our Muslims patients tend to have a higher pain threshold, and they are accepting pain as it's a good deed, and they can bring them like clearing of their like sin and all of that. So cultural influence can play a role in pain response. Psychological factor also can play a role in that. People also could be having pain, but also under sedation or having delirium. And this can mask some of pain behaviors when we are assessing by utilizing behavioral pain assessment. As I mentioned, physiological indicator could be present, but it also could confound our pain assessment. In our nonverbal ICU patient, also the timing of observation, we do it intermittent, and this may miss some fluctuation in pain leading to inadequate pain assessment. Another issue is the familiarity and inadequate training. So maybe we have a new staff, or some people maybe not have well trained on doing the behavioral pain assessment, and this could result in inconsistent pain score. I can imagine if we talk if we ask two nurses to conduct the pain assessment or the behavioral pain assessment to the same patient, we will end by having different results, certainly. So the key is to balance efficacy and safety. And how we do that? We know now that opioids are effective for pain management, and we know that their use is complicated by risk factor. So the two things that I will stress is to have a patient-centric approach. You have to tailor the pain management as well as assessment according to your patient. If the patient is opioid naive, any other comorbidity, their illness severity score, all these have to be in account when you are dealing with opioid. Also, not only multimodal analgesia, but having a multidisciplinary team managing pain in patient in ICU is very important. Have intensivists, anesthesiologists, nurses, as well as pain management team and pharmacists is a key players in managing patient pain while utilizing opioid. So what approaches we can shed light on quickly is, first of all, multimodal analgesia, and this is very well known. We're combining different opioid with non-opioid to minimize opioid doses. So any aspect or any management that can reduce opioid consumption certainly will reduce the negative outcomes coming out of it. We have to set realistic pain goals, and this not only by us, but also by incorporating patient and family whenever visible in their pain management plan. And this is where we can do personalized strategy based on the patient characteristic, medical history, and severity of illness. So I'm going to talk briefly about some non-opioid analgesic, adjunct therapy, and regional anesthesia. Well, acetaminophen, readily available, very cheap, it's very safe and effective for mild to moderate pain in ICU. We can incorporate it in our protocols, and we can see that it can reduce the pain severity as well as reduction in the opioid consumption. Non-steroidal antiviral may be not well studied in ICUs, and it has inherited risk factor. I don't advocate for its routine use. However, if you have both surgical, you can use it a couple of times, not as a routine, maybe as needed. It can be effective in pain relief, but cautiously in patient with high risk. If you have a patient with a neuropathic pain origin, the guideline highly recommending gabapentin and other neuropathic pain management. And this is, again, for a specific population, and that has a strong recommendation in the latest version of the guideline. Other ketamine, I just talked about ketamine a while ago, 2 hours ago. And NAMDA receptor antagonist, yes, we can utilize it for severe pain, and it can preserve the respiratory function and prevent the respiratory depression, which is one of the disadvantages of opioid. Other also muscle relaxant, they have published 2 studies about methocarpamol use in post-traumatic pain management. Specifically, I'm talking about like rib fracture or chest type of trauma. And we have a very good result in reducing morphine requirement in that study. So methocarpamol, baclofen can be effective in managing some kind of pain, specifically the ones that has muscle origin. Lidocaine patch as well, the guideline talked about a lot of localized or local anesthesia and local pain agent. I'm shed light on lidocaine patch. I have successful result with lidocaine patch. And I use it for localized pain in my patient with post-surgical. I recall a case where the patient has rib fracture and we tried everything, and that was post CPR rib fracture. I just ordered 2 lidocaine patch to put on both sides, and that was amazing result, and the patient pain have relieved tremendously after utilizing it.
5 minutes.
Okay, sounds good. Another approach is to do opioid rotation. Well, whenever you have a patient with inadequate pain relief with one opioid or intolerable side effect, try to switch to another opioid agent to improve the patient analgesia. But keep in mind, equi-analgesic doses count for a cross tolerance, because there is certain percentage that you have to count for a cross tolerance and be patient specific as well. Another thing is tapering protocol. Do not apply standard tapering protocol to all your patients. You have to assess your patient baseline pain level, as well as the pain level during or currently when you are deciding to tapering down, the clinical status, the comorbid. The longer the patient on opioid, the slower tapering schedule should be. We tend to just cut to the half and then 20% and 15%. Well, you have to remember how long this patient has been on opioid. Someone 2 weeks on opioid, and it's not similar than another patient is on like 2 days or 3 days on opioid. Patient history, opioid tolerance, opioid dependence, prior substance use, people with history of substance use before admission, all these are very important. Last but not least, I'm very advocating for adapting opioid stewardship program, and this is on a larger scale. It's not one patient at a time, but look to your use of opioid in ICU. Ensure that you have appropriate dosing and the duration of opioid. Promote for multimodal analgesia and non-opioid alternative. Try to reduce the consumption of opioid without compromising pain management, and educate your staff or healthcare staff to improve their prescribing behaviors and the practice. I have mentioned also the assessment, how we can improve assessment while utilizing multimodal assessment tools, not only depend solely in one behavioral scales.
2 minutes.
Provide the training and education. Also can adapt some innovative technology for capturing the fluctuation in pain, like wearable device. I'm sure there is tons of innovative ideas to help in assessment. Encourage also patient whenever visible and family to talk about their level of pain. So the final takeaways from my presentation, well, opioids are essential, but remember they are very risky. They are very crucial to our patient. However, it comes with significant risk. Multimodal analgesia, multidisciplinary team, opioid stewardship, evidence-based protocol, all are very crucial to find that balance. Personalized approach and tailor the plan, and depends on your patient. We still need tons of research in non-opioid alternative. There are a lot of agents I haven't mentioned here can also have a role in minimizing opioid consumption. We need to enhance our monitoring and assessment. Are we doing a great job? Are those behavioral skills need to be revisited again to shape our future of pain management and assessment? With that, I've reached to the end of my presentation, and thank you all for your attention.
Thank you. Thank you, Dr. Ahoud, for the nice presentation. Now we come for the last speaker, to be presented by my colleague.
Thank you. Thank you very much, Dr. Hanouf. It is my pleasure to present our speaker number 4. She's Dr. Nada Alhani. She'll be speaking to us on andexanate alpha and 4-factor prothrombin complex concentrate in the battle against intracerebral hemorrhage. Dr. Alhani is a consultant critical care clinical pharmacist. She holds a Doctor of Pharmacy degree from the MCPHS University and has completed several prestigious ASHP accredited pharmacy residencies training at the Brigham and Women's Hospital and the University of Arizona, USA. Dr. Alhani has held various leadership positions throughout her career, including a board member of the Critical Care Pharmacy Specialty Network within the Saudi Society of Clinical Pharmacy. She's a board certified in critical care pharmacy and pharmacotherapy and is actively involved in research, teaching, and professional organization. You are welcome, Dr. Alhani. You have 20 minutes. Thank you.
Absolutely. Oh, they're going to wait for it. Well, thank you so much all for staying for the last presentation. I promise it's going to be very interesting and epic battle to see who's going to win the PCC or andexanate alpha when reversing anticoagulation and intracranial hemorrhage. And I would be very happy to hear your feedback, experience, and your opinion of using PCC versus andexanate alpha. We're just going to take a few minutes until the slides is here. Okay, wonderful. So today I'm going to go over some overview of intracranial hemorrhage and its complication. Also, we're going to go over the pharmacology, mechanism of action of andexanate alpha for factor PCC and the different evidence of using those agents in actually reversing factor 10A inhibitors. So let's go over like a quick patient scenario. Let's say we have a 75-year-old woman with a history of atrial fibrillation on apixaban, presented to the ER an hour after noticing difficulty reading and found to have 3 centimeter left occipital intracranial hemorrhage. Her blood pressure is 164/102. And the CT imaging of her brain showed an intracranial hemorrhage. What should be the anticoagulation reversal to use in this patient, and what should be the hemodynamic goals? So intracranial hemorrhage, generally speaking, looking into statistics, it accounts for 10 to 15 of stroke in the US, disproportionately higher among lower resource population. It has early mortality, like 30 to 40%, within less than 30 days, no trend towards improving mortality. Intracranial hemorrhage, while anticoagulated, is associated with high morbidity and mortality, with around 3 to 6 times higher than non-anticoagulated patients. Hematoma expansion, I want you to remember this word very well. So this is the main problem when it comes into intracranial hemorrhage in anticoagulated patients. This is our main problem that we need to avoid is the hematoma expansion because it is potentially modifiable, associated with worse outcome, and it is associated with acute blood pressure reduction. Anticoagulation use account for 18% of intracranial hemorrhage in general, and actually it is likely will increase over time. The importance of hematoma expansion is the total expansion volume is powerful predictor of outcome. With hematoma expansion, it is validated that it is an independent predictor of poor outcome even after accounting for the baseline intracranial hemorrhage volume. The absolute increase between 7 to 12.5 ml has both been validated as being critically or clinically meaningful with regard to 3-month outcome. The intracranial hemorrhage can occur with hematoma expansion as an independent predictor, poor outcome, and prognosis as well. So here, just to remind you of how hematoma expansion can affect the functional scores in patients with intracranial hemorrhage. So if you remember the modified ranking score, as we go higher with the score, it leads to more disabilities on those patients. And with 1 point increase of, with 1 ml, increase in hematoma expansion, we can see 6% more likely for 1 point increase in modified ranking score. with 10% increase in intracranial hemorrhage volume, that would lead into 16% increase. And if you go even higher and higher, it's even leading to a higher number or rate of modified ranking score. There is other intracranial hemorrhage outcomes that we can look at in those patients, like the ICH score, which is assessing 30 days mortality, as well as the FUNC, the FUN, which is the functional independent at 90 days. And both of them, they account into the intracranial hemorrhage volume upon presentation in those patients. Why hematoma expansion is something that we try to avoid is because when you have an intracranial hemorrhage with controlled hematoma, you can end up having a patient enjoying his life with some assistant and walking around. With hematoma expansion, we're talking about a patient stuck in the ICU with comorbidities. So now talking about the DOAC, or the anticoagulants, in specific that we're talking about in this presentation, which is the DOAC in general, that are the direct factor 10A inhibitor that has been used, steadily used over the last year. As you can see from the graph here, you can see the yellow line is increasing over time because we're using DOAC even more than the black line, which is the warfarin, that's been diminished over time. So while factor 10A inhibitor has less bleeding compared to warfarin, but bleeding can still happen. So intracranial hemorrhage can still occur in around like 1,000 patients with AFib treated with DOAC for 1 year. Between 2 to 5 will experience intracranial hemorrhage. The treatment of major bleed is very much controversial. We can use the 4-factor PCC, or now we have the new reversal agent, which is the andexanate alpha. So for major bleed that requiring hospitalization, that's this just to demonstrate how the number is increasing over time because of the increased use of anti-10A or factor 10A inhibitors, and the intracranial hemorrhage account for 9% of those bleeds. This is a quick demonstration of a systematic review in patients who are receiving DOAC or vitamin K inhibitors and the incidence of intracranial hemorrhage. And you can see that the percent of intracranial hemorrhage with warfarin is 26.5% versus 24.3%. So for mortality rate on those patients and patients who experience intracranial hemorrhage. So how does DOAC? What are the different DOACs, how they are working? So DOACs in rivaroxaban, apixaban, and edoxaban, which is a factor 10A inhibitor that inhibits 10A directly, which would also stop the conversion of prothrombin to thrombin. As you can see from the table here, they are all can be used through an oral route with a quick half-life between like 5 to 10 hours in terms of half-life. So over the decades, we have warfarin since 1953, and then around 50 years after, we started to see those new oral anticoagulatant emerging, starting with the dabigatran, rivaroxaban, apixaban, edoxaban, and we had to wait until 2018 until the antidote emerged to work on those new oral anticoagulants. So it's around 7 years while we were using those new oral anticoagulant or direct oral anticoagulant until we had that reversal agent. So in our practice and in preclinical models, we were depending very much a lot on the 4-factor PCC that help us to ride the train or ride the plane until we had that anticoagulant in the market. So let's just have a quick comparison between andexanate alpha and 4-factor PCC. The indication is very much for andexanate alpha to specifically reverse the anticoagulation in patients treated with apixaban or rivaroxaban. It acts directly as a recombinant modified human factor Xa decoy protein that bind and sequester to rivaroxaban and apixaban. On the other side, the 4-factor PCC, the vitamin K antagonist reversal in patients with acute major bleed or a need for urgent surgery or invasive procedure. It increases plasma level for vitamin K-dependent coagulant, factor 2, 9, 7, and 2. As well as protein C and S. Here is a quick demonstration how the native factor 10A and the andexanate alpha looks very much similar to competitively bind on the receptor. On the drug. So here also a quick PK/PD. Again, the dosing of andexanate alpha. We have 2 dosing, the low dose and the high dose in terms of initial bolus and infusion. The different factors that will help us to determine the appropriate dose is the last dose given of the rivaroxaban or apixaban and the time of the last dose as well. Because time is brain, andexanate alpha is great in having a rapid onset and dose-dependent effect. So within 2 to 5 minutes after the bolus administration, we will see a decrease by 95% of apixaban and 92% of rivaroxaban. So it's a wonderful agent to reverse the anti-factor 10A activity that persists for up to 2 hours after completion of the infusion. So now we can see how wonderful the andexanate alpha is. So let's try to see if there is any studies that compared andexanate alpha to 4-factor PCC. So there is multiple retrospective studies that looked into both agent to compare both agent. All the 3 trials were done in 2020 or published in 2020. We can see that andexanate alpha was associated with a lower rate of in-hospital mortality, higher rates of good or excellent homeostasis or good or excellent homeostasis efficacy that was achieved in 82% in patients with apixaban. But actually there was no head-to-head comparison. So Hunter and his team, they tried to get some data from 2 different trials that were single-arm studies, which is ANEXA-4, which is a single-arm study that looked into patients who receive andexanate alpha to reverse apixaban versus RETRACE-2 that also examined patients who received 4-factor PCC to actually compare the occurrence of hematoma expansion and the clinical outcome. And they found that the rate of hematoma enlargement and also the absolute intracranial hemorrhage volume change were great in andexanate alpha. However, also 4-factor PCC has a great also outcome in terms of in-hospital mortality and also functional outcome, which is the modified ranking score after 30 days. So if you see here on the results, in terms of hematoma expansion of more than 35%, the patients who received andexanate alpha, only 11 patients had a hematoma expansion versus 24 patients in those who received 4-factor PCC. And with the adjustment into the co-founder, patients who received, only 10 patients who received andexanate alpha has hematoma expansion versus 21 in 4-factor PCC. And here you can see how the secondary outcome very much favor andexanate alpha in terms of in-hospital mortality, intracranial hemorrhage volume change, and post-treatment modified ranking score. And here also to demonstrate how mortality at day 30 favor andexanate alpha versus usual care. But again, remember, this is a data collection between 2 different articles, 2 different trials that try to match between patients. So let's see what the guideline recommends. So in the 2020...
Thank you. 5 minutes more.
Oh my God.
Thank you.
So in 2022 intracranial hemorrhage guideline, you will see that the guideline very much does not favor any specific agent. So we'll tell you that andexanate alpha is an appropriate or reasonable to reverse an anticoagulant effect versus the 4-factor PCC also can be considered agent as a good agent. And even if you look into the other guidelines, most of them will not have a specific conclusive recommendation, as it can be reasonable or we can consider. Then, until we had this great and wonderful trial that we were waiting for, which is a phase 4 multi-center prospective randomized open label blinded endpoint trial that examined andexanate alpha to usual care, including 4-factor PCC, in one-to-one head comparison. And the main endpoint was hematoma or hemostasis at 12 hours with the hematostasis definition is less than 30% hematoma expansion, NIHSS score as less than 7 at 24 hours, and there is no rescue therapy needed within 3 to 12 hours. However, this trial has been stopped early after meeting stopping rule for efficacy during interim analysis. And if you look into the characteristic of the patients who were in the study, you can find that there is very comparable percent of female versus male. However, female were a little bit lower, and the andexanate alpha with 42%. Most of the patient, 90% of the patient having atrial fibrillation and diabetes. They found that patients who receive andexanate alpha has a higher past medical history with diabetes, and we will talk about this. We will point this later. The anticoagulation received all the three DOACs, and the site of bleeding, majority were having intracranial hemorrhage. However, there was some intraventricular, subarachnoid, and subdural hematoma as well. This is the other baseline characteristic. You can see that the usual care, they mostly received the PCC, mostly 4-factor PCC, 3-factor PCC as well. But also, if you look into the baseline, the NIHSS score for both were around 9. So those are not, so upon presentation, patient was not very sick also. That may correlate with using apixaban, although it can lead to intracranial hemorrhage, but it might not be that severe as warfarin. But also, we need to keep this in mind. So the primary outcome, we found that actually 67% of the patients who received andexanate alpha were able to achieve hemostasis at 12 hours versus 53%. And that was very wonderful result, which is 13.4 adjusted absolute increase in effective hemostasis with andexanate alpha versus a usual care. However, if we break down the primary endpoint, we will find that the major difference were the hematoma volume, the reduction in hematoma volume between the two arms.
2 minutes more. Thank you.
Sure. Okay, for secondary endpoint, there was almost 26.9 reduction in anti-10A activity versus 94% in andexanate alpha, which is a very great result in reversing the agent, but it's very much expected because it's the antidote for this agent. So within 1 hour to 2 hours, there is almost very close to 95% reduction in the amount of andexanate alpha. However, the bad guy here is the thrombosis. Patients who receive andexanate alpha had a higher rate of thrombosis than usual care. So around like 10% of patients who received andexanate alpha had more than or equal to 1 thrombotic event versus 5% in the usual care. And also ischemic stroke happened in 17 patients, which is 6% versus 1% in usual care. Also, at the same time, if you look into mortality rate were higher with andexanate alpha versus usual care. However, it was not statistically significant. The only statistical significance was with the thrombotic events. So in conclusion, among patients with intracranial hemorrhage who were receiving factor 10A inhibitor, andexanate alpha resulted in a better control of hematoma expansion than usual care, but at the same time, we are experiencing more thrombosis and may increase mortality, but it was not very significant. So now the decision is, would you use andexanate alpha or not? So generally speaking, in the guideline, if there is a patient who presented with intracranial hemorrhage post factor 10A, we will look on the availability of andexanate alpha. If it's available, you have to go with it. If not, we go with the 4-factor BCC. For the availability of andexanate alpha was always a challenge in Saudi Arabia in different institutions. And if you can see in the picture here, even in the United States, it's not widely available yet because it's a new agent. However, the good news for Saudis that now it is approved by the Saudi FDA authority. And in my institution, from a personal practice, we got andexanate alpha, but for a very minimal or a very, very small number of patients. We have it for 2 patients per year. So the battle between PCC and andexanate is strong and epic, and I'm not sure who are those 2 patients who really qualify for andexanate alpha versus PCC.
Thank you very much.
Thank you.
Professor
And this is the
Al-Hani.
end of my presentation, and thank you so much for your kind listening.
Thank you. Our Professor Jorge Hidalgo sent apology that he's in another meeting. I will now hand over the microphone to Dr. Hanouf to take charge of the question and answer session. Thank you.
Thank you very much. I'd like to invite all the speakers, please, to be on the stage for any questions. And from the audience, if you have any question, just raise your hand, please. Thank you, everybody, for the nice presentation. Wide range of critical care pharmacology, well presented. So if anyone is having any question. يمكن أحد مستحي ولا شيء. هيدي بروف إبراهيم. المايك.
Yeah, so the question was, in my institution, do I use propofol or dexmedetomidine for sedation? And, it's right now we've really moved to a multimodal sort of daily evaluation of sedation. So we don't even have a sedation protocol. We establish a RAS each day, and it's important to keep the goal RAS. And we talk about patients on rounds in terms of what's the best sedative for that patient this day, if they even need sedatives, right? Sometimes patients don't need to be on continuous sedatives. Not everybody needs to be. And then it comes down to, is Dex the better choice or is propofol for many patients? And I think it's important, to be thinking about the pluses and minuses of each agent. And it really gets down to sometimes sedation goals. We know that there's not a profound benefit of Dex over propofol or vice versa based on SPICE-3 and the MENS-2 study for our critically ill patients. So it gets down to individualization. Are we, does the patient have agitated delirium? Are we trying to do an SBT and they're failing the SBT because of respiratory depression from propofol, with or without opioids? So it kind of depends on that patient, what we're seeing. We don't really have one choice. We use both. I don't know if I answered your question.
No, that's great. In your institute, again, I do have a hard time with my house staff nighttime. Someone who, like, do you have, or let me put it this way, do you have a nighttime sedation or or sleep medication that you prefer? I have trouble with my resident or my house staff. Everyone has his own choice. And in the morning, we come 6 o'clock in the morning, they just turn off everything. And nighttime, the patient snored. So what's your ideal, probably, sleep?
Yeah, I think, there's definitely some emerging data that we know propofol disrupts sleep and is bad for sleep. Dexmedetomidine, definitely some good evolving data suggesting dexmedetomidine improves sleep. And so I think if a patient has, especially if they have delirium and they're agitated at night, their circadian rhythm is screwed up, I think dexmedetomidine would be my go-to drug for that patient if it's that severe. But I think the most important thing for sleep improvement is non-pharmacologic, right? Decreasing noise, quiet environment, relaxing them, thinking about how they sleep at home, right? Many patients, whether they can sleep on their side or they have to sleep on their back. I mean, there's many, many things. People come in to the ICU with very, often disruptive sleep even before they became critically ill. So thinking about all these, how people like to sleep. Do they like white noise? Some people like earplugs. There's many things. I think for medications, there's not a perfect drug. I think benzos are bad, but I think certainly, you could try some melatonin. I'm not a big proponent of melatonin by itself. I think you need to do it with other circadian entrainment interventions. I think, we certainly sometimes use the non-benzodiazepine sleep aids, and sometimes we'll use a sedating antipsychotic like quetiapine. It could sedate people. So it's a mixture, but there's not one golden drug.
And sorry, one last question,
Okay.
comment, and that's probably just for those of us who practice in this country.
Yeah.
I'm an ICU consultant. I worked in 3 different or 4 different places, and my impression from the local practices, now we come to conferences, we go to different conferences here and there, and we hear all of the non-pharmacological intervention that's the best modality for patient comfort and to reduce delirium. However, I just urge everyone to allow patient visitation. So unfortunately, part of our ICUs here in this part of the world, we do not allow patient families to come to visit. They see patient outside. You are like, you come, you view your dad, your mom from a window. You can't touch, you can't talk. And that's the least of what you want to do to reduce the delirium or prevent delirium.
Absolutely, and I think anxiety plays a big role, and I think patients, even if they're critically ill and the family's there, it dramatically reduces anxiety. And the families are such a big source of information, right? They can tell you, most of us don't know the patient that well, and the families will tell you what they like, what they don't like. It's just such a beneficial effect, yes. Thank you, your points you raise are so important.
Is there any other question? Yeah. We have a question here in the front. Maybe a quick question because we have left 2 minutes only.
Thank you very much for great talks. I have a question for Dr. Ahoud. I just wanted to know, over the years, has there been any type of stewardship program to reduce the use of opioids? What has been the challenges to do so, and what has worked for you to increase the multimodal analgesia and limit the opioid use?
Thank you for this great question. Well, if I'm talking about my own experience in my practice, unfortunately, I haven't adapted the opioid stewardship. I'm doing it one patient at a time, but definitely there is tons of research has been published about successful stories of adapting opioid stewardship program. Probably we can have a collective efforts with you guys, colleagues here in Kuwait, and with across the borders, and our colleagues in USA to come with stewardship or standardizing the stewardship of the opioid. But for myself, I haven't adapted as a structured program. There is always 2 stewardship that I'm thinking of it and keeping it in the back of my mind. One is the PPI stewardship, and the other one is the opioid stewardship. And those maybe one time I will do it, but I think that it's a very important program to think about it if you want to change the practice in your setting. There is tons of publication about it, yeah.
Thank you, everybody. And if there are no more questions, I'd like to thank you all. And to close the session for today, the second day, this is the last session. Thank you all for being here till now, and we'll see you tomorrow morning, inshallah. Thank you, everybody.